Good morning. My name is Kendall Burnett, and I am going to be doing my journal club on the clindamycin versus trimethoprim sulfamethoxazole for uncomplicated skin infections. This study was funded by the grants and consultation fees from the National Institute of Allergy and Infectious Disease National Center for Research Resources, as well as Cubis, Dorada, and Pfizer. All of the authors were serving on the advisory board of the three pharmaceutical companies that were listed in the funding. A little background on this study. Um, Skin and structural infections are very prevalent in the United States. Even though it's a vast amount of treatments for these infections, not all have the ability to cover what they considered the community-acquired methicillin-resistant Staphylococcus aureus, which is MRSA. In this study, they were basically trying to figure out which, between the two drugs that they chose, which one would be the most efficacious in the patients that they chose. According to the article, there's about 14 million cases, patients that have suffered from the infection in 2005, and that it's also been said that about 850,000 cases people were sent to the hospital because of this infection. And the thing that makes this skin infection so dangerous is that it could enter into an individual's systemic circulation, which can cause an even more complex matter of bacteremia, and worst of all, an occurrence of death if not properly treated. The ultimate goal, like I said before, was to see whether sulfamethoxazole, trimethoprim, or clindamycin would be the best choice in providing the desired results of the eradication in different patients that have an uncomplicated skin infection. The trial design, it was basically a multi-centered, prospective, randomized, and double-blind clinical trial, meaning that when it came time to providing these medications to the patients, both the patient and the provider that was the one that frequently gave the medications to the patient was not aware of what drug or which drug would be used in each of the groups. A total of 524 patients that were enrolled in this study. They were recruited from 4 different locations and from urgent care clinics, emergency departments, as well as other affiliated clinics. The 4 institutions that were used were the University of Chicago Medical Center in Chicago, Illinois, the San Francisco General Hospital in San Francisco, California, the Arbor UCLA Medical Center in Los Angeles, California, and the Vanderbilt University Medical Center in Nashville, Tennessee. This study was approved by the Institutional Review Board, and in order for a patient to be eligible to be put into the study is that if they had two or more signs and symptoms of the complicated infection, which were erythema, swelling or induration, local warmth, a purulent drainage, and tenderness to pain or palpitations. Of the uncomplicated skin infections, they were to be treated, they would be eligible if they had cellulitis, an abscess, or both, considering if the lesions both were present, both an abscess and cellulitis. What excluded a patient from being included in the study were superficial skin infections, an infection site that came about if there was a bite or a animal or human bite, a patient with a high fever, someone or a patient could provide proof of immunocompromising conditions such as diabetes or chronic renal failure, if the patient was morbidly obese, if the patient had past antibacterial therapy with anti-staphylococcal activity within the 14 days before the study was conducted, if they had cancer, or they happened to live in a long-term care facility. Of those, this is what had excluded them from being chosen to take part in this study. The people that they chose to take part in the study, it was a various amount of men, women, and children of many different ethnical backgrounds. Like I said before, there was 524 patients enrolled, including 155 children. This article aimed to show the results of the group that was placed in the larger abscess cellulitis group. The primary outcome was to achieve a clinical cure within a 7 to 10 day period right after the treatment was given. This was designed as a dominance trial with about an 80% power percentage to detect an absolute difference between the two treatment groups. Secondary outcomes were the cure rates at the end of the treatment and at the 1 month follow-up visit. The cure rates that we observed were the adult and pediatric population. At the end of the treatment, there was a follow-up where they did a follow-up at the end of the treatment, at the test of cure period, which was the 7 to 10 days after completing the course of therapy. And the last type of follow-up they did was at 1 month follow-up, which was around day 40. The duration of the study, they started recruiting people from May 2009 through to August 2011. That is when the patients were recruited to from the 4 areas as stated earlier. The patients were stratified into about 1 or 2 of the groups based on what type of infection that they had before they were put into their randomized groups. The initial null hypothesis was that clindamycin and sulfamethoxazole trimethoprim would have the same rates of cure. In order for this to be done, the comparisons, they were achieved through the use of the analysis of variance test, Fisher's exact test, and the chi-squared test, in which these tests were two-sided. The baseline characteristics, it was the equal amount of patients that were treated based on what type of infection they had. The average age of a patient in the study was about 27. The ultimate outcome at the end of this was a clinical cure in the test of cure section of this study. The 2 types of treatment, the clindamycin and the sulfamethoxazole trimethoprim, they both were effective and cost effective for patients. The adverse events were only mild to moderate. The most common were diarrhea, nausea, vomiting, and rash. And since clindamycin was used, there was a worry of C. diff, Clostridium difficile, causing pseudomembranous colitis, but there were no cases reported of that C. difficile associated diarrhea. The strengths of the study was that the fact that it was double-blind, randomized clinical trial. It decreased the incidence of causing bias against the drugs that were chosen. It provided a detailed systematic review on the effects available, and the rate of withdrawal or dropout was fairly low. It was about 10 to 20%. The weakness of this study, I would say, was the fact that the dosages of clindamycin and sulfamethoxazole for skin infections, it was not well defined. According to the article, it says that some facilities suggested that a patient take a dose twice the dose originally proposed, whereas some patients took the recommended and proposed dose. The proposed dosing was to give clindamycin as a 150 milligram tablet 3 times a day, and sulfamethoxazole trimethoprim was given at doses of 160 milligrams of trimethoprim and 800 milligrams of the sulfamethoxazole component to be administered in a single strength tablet 2 times a day. Of course, the pediatric doses were adjusted based on the child's body weight, and liquid suspensions were also available for pediatric dosing. The arms in the study were sulfamethoxazole, Bactrim, and clindamycin, Biaxin. Of the 524, 264 received clindamycin treatment, whereas 260 received the Bactrim treatment, including the children. Another weakness associated with this study that I felt was, since Staph aureus is an infection that can often reoccur, the 1 month follow-up with the patients, I believe, was not the best way in determining the true success of the drug. Maybe if they went back around like maybe 2 or 3 months period after the treatment to see if there was a reoccurrence, that may have been a better option to see the true results, the true efficacy of these drugs. At the end of the study, it showed that about 80.3% that were treated with clindamycin showed a successful cure rate versus the sulfamethoxazole trimethoprim treated group, which was 77.7%. So, in conclusion, in this case, patients that were in the clindamycin group seemed to have a better rate of cure than those in the Bactrim group, which tells us that our null hypothesis in the beginning was not accepted. So there was no large difference in the overall treatment of patients with the uncomplicated skin infection. Thank you so much for listening to my journal club, and I hope you have a very great day.